good morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo naroon. Welcome to our 248th episodes of the Health Updates webinar series brought to you by the University of Philippines. Thank you for being part of our credible online community, and to all those who have just discovered us today, welcome po at sana po marami po kayong matunan sa ating very important topic, which is endometrial cancer po. Dun po sa sa line matres natin. Very significant po no na gynecologic malignancy. It still presents us with iba't ibang challenges. And pag-usapan po natin prevalence, risk factors, maybe nuances po ng clinical manifestation. Paano po ba natin to mas madaling ma-identify, ma-recognize para po mas mabilis po ang ating pag-refer sa mga espesyalista. Especially po no kung mayroon po kayong nararamdaman like abnormal uterine bleeding, mga pagdudugo po, lalo na po kung kayo na po ay menopause na. So, yun po ay very important na simptomas po natin. Maybe other symptoms that will be talked about by our excellent panel of speakers. We'll also discuss epidemiological trends specific to the Philippines po, no? And then incidence rates, factors, etc. Demographic vulnerabilities also. And ano po ba yung impact nito ng kondisyong ito sa ating society. Will also, hopefully, will be able to discuss ano po ba yung advancements na in terms of endometrial biopsy techniques, hysteroscopy, specific tumor markers, molecular profiling, that sort of thing. And then sa management naman po, including sa mga surgeries, so hysterectomy, salpingo-oophorectomy, lymphadenectomy. So yung mga ganun po, no? And maybe there are minimally invasive techniques pertinent po para sa atin. And then yung adjuvant therapies din po, pag-uusapan po natin, chemo, radio, brachytherapy, hormonal therapy po. Sa lahat-lahat po ito, in diverse clinical scenarios, sana po ay makover po natin in just 1 hour in our program. This is the Health Updates program and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during our regular Friday, and also my pleasure and honor to host this program together with Dr. Stella Mariose. Ma'am Stella.
Good afternoon, Raymond. Good afternoon to all our participants here in the live broadcast of the Zoom webinar, and to all those watching via live streaming on TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and of course, those watching in TVUP Signal TV channel 101. Our presenter for today is Dr. Marie Aleli de Castro Malig, who is the Vice President of the Society of Gynecologic Oncologists of the Philippines, and she is also the Chairperson of the Department of Obstetrics and Gynecology at the Perpetual Health Medical Center in Las Piñas, and the head of the section of Gynecologic Oncology at the Asian Hospital and Medical Center. Our reactor is Dr. Rene Vina G. Sikam, who is a clinical associate professor from the UPPGH Department of Obstetrics and Gynecology. For this week's episode, we will discuss how we can learn about early recognition, referral, supportive care, and pharmaceutical management of endometrial cancer patients as we reinforce the multidisciplinary nature of optimal patient journeys. But before we go to our presentation, Raymond will introduce our person on the street video.
Thank
Back
you,
to you,
Dr.
Raymond.
Thank you, Dr. Stella, for our person on the street video. You already know, and this really for those who are first timers po in our program, we set our discussion into context by interviewing po no what the common folks on the street know about in this case endometrial cancer. So our questions to our interviewees are as follows. Number 1, ano po sa tingin ninyo ang sintomas ng cancer sa matres? Sa tingin po ninyo, normal po ba ang patuloy na pagdurugo kahit menopause na? At paano po nakukumpirma ang pagkakaroon ng cancer sa matris at paano po ito kaya ginagamot. Please watch this.
Possible po yan is may heavy bleeding po, monthly period. And then kapag may sexual contact po, masakit siya. During, after ng contact with your partners, irregular po na pag-menstruation po.
Ito po ay base lang dun sa nangyari sa kapatid ko. Nagsimula po sa pagdurugo, hindi po tumigil yung pagdurugo sa matres niya.
Normal po ba sa tingin ko yung pagdudugo kapag menopause? Sa akin hindi. Kasi siyempre pag menopause ka, dapat wala ka ng monthly period. So, kapag po may ganito pa rin, much better na mag-consult tayo sa OB natin or sa mga licensed doctor na mas nakakaalam po. And then,
Kasi po, pagkakaalam ko po kapag menopause na po is wala na po parang excel po ang babae para sila po ay magkaroon po ng menstruation. Ang pagkaroon po.
Hindi po normal yung menopause ka na dinudugo ka pa po. Kasi sa case ng kapatid ko po, sa age niya ay menopause na siya. Pero bakit po dinudugo pa rin po siya? Kaya doon po namin nalaman na may case na po siya ng cervical cancer.
Pwede ito siguro malaman by pap smear po, yung liquid phase, or magpapatest ka din ng HPV vaccine, HPV test, or via ultrasound po na trans-B.
May certain na testing po dyan patungkol po sa cancer po ng mattress.
Hanggang sa pagdating po nung maminipose na siya, nagsimula na po siyang magdinugo. Hanggang dire-diretso na po siya. Tapos na hindi na po kinaya niya, pinaoperahan po siya. Doon namin nalaman na marami na po palang bukol yung mattress niya. Doon na po nag-umpisa na nagkaroon na siya ng cervical cancer. Pero naoperahan po siya. Tapos po, inuwi, naging normal. Tapos ng mga ilang buwan, nag-umpisa naman po siyang dinugo. Nagdire-diretso na yung pagdurugo sa kanya. Hanggang sa yung katawan niya, parang bumigay na. Parang nanghihina na siya.
Pwede po ito by surgical siguro, and then chemotherapy po in patient if nag-positive po siya sa pathology results po niya na meron siyang cervical cancer po.
Pwede naman pong magamot yan kung hindi pa siya masyadong malala. Kasi sa case ng ate ko parang naipagamot lang po siya nung medyo malala na siya Tapos bumigay na yung katawan niya. May paraan naman po dyan, may chemo para magamot pa siya. Kaso po kung ikikemo at mahina na rin ang pangangatawan, hindi na rin po kakayanin. Ganun po yung nangyari sa kapatid ko. Kinemo siya, naoperahan, masyado na pong mahina yung katawan niya. Hindi na kinakaya.
Okay, thank you so much to our production team po, no? And really heartfelt testimonial sharing po from our interviewees. Very, very grateful for their time and then really opening up their personal stories po to us. So, before we proceed with our webinar program, just a little bit of housekeeping that all certificates of attendance have been given to those who watched at least 50% of the webinar duration. So, we receive, I think, one, if I'm not mistaken, maybe one or two email inquiries po, no? So if you have any questions, please feel free to email us at our up.edu.ph account. For our webinar today, we'll have a standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. So without further ado, Dr. Stella Jose will introduce our main speaker for today.
Our main speaker is Dr. Marie Aleli de Castro Malig, who is the Vice President of the Society of Gynecologic Oncologists of the Philippines. She is also the chairperson of the Department of Obstetrics and Gynecology at Perpetual Health Medical Center in Las Piñas and the head of the Section of Gynecologic Oncology at the Asian Hospital and Medical Center. So without further ado, we present Dr. Marie Aleli de Castro Malig.
Hello, good afternoon. I am Dr. Marie Aleli or Aya de Castro Malik. I am a gynecologic oncologist and I will be talking about advances or updates in the management of endometrial cancer. Okay, so let me start by introducing my two patients who were both diagnosed with endometrial adenocarcinoma or cancer of the uterus. AR, married and in menopause. She's a 54-year-old Gravida 1 Para 1 1001. She is obese with a BMI of 27. She is also hypertensive and diabetic. She has been experiencing postmenopausal spotting for a year before she consulted her OBGYN, who referred her to me. The delay in consultation was because she was thinking that her symptoms were secondary to menopause. So physical examination was unremarkable. The OBGYN requested for a transvaginal ultrasound, which showed a thickened endometrium. The OB then did an endometrial biopsy at the clinic, which showed endometrioid adenocarcinoma, grade 1. RJ, on the other hand, is a 32-year-old newly gravid woman who recently got married. She is also obese with a BMI of 25. She is not hypertensive nor diabetic. However, at 22 years old, she was diagnosed with polycystic ovary syndrome, described as episodes of amenorrhea for several months, followed by prolonged bleeding. She took oral contraceptive pills for 6 months but failed to follow up with her OB. It's like she has accepted that her cycles of amenorrhea are already part of her normal cycles. So her pelvic exam is also normal, and the transvaginal ultrasound requested showed thickened endometrium and polycystic ovaries. She underwent hysteroscopy guided biopsy of the endometrium, which showed a 1 centimeter tumor that was read as endometrioid adenocarcinoma grade 1 by the pathologist. So 2 different women, one postmenopausal and the other is just 32 years old, both with endometrial adenocarcinoma. So what is endometrial cancer or cancer of the uterus? It is the 4th most common cancer in women after cancer of the breast, the lung, and the colon. In terms of mortality, it ranks as the 6th most deadly cancer in women. And notably, in 2023, uterine cancer surpassed ovarian cancer as the most lethal gynecologic cancer in the United States. A reminder of how the burden of this disease is shifting. What's even more concerning is that cases are on the rise worldwide. The highest rates are currently observed in North America, in Europe, Micronesia, Polynesia, and Australia. But the increase isn't limited to high-income countries. There is increasing incidence in nations like Japan, the Philippines, the Belarus, Singapore, Costa Rica, and New Zealand. A woman has about a 3.1% lifetime risk of developing endometrial cancer. That's roughly 1 in every 32 women. So 1 in every 32 women. The median age at diagnosis is 64 years old, meaning it most often affects postmenopausal women, though younger women are not exempt. If caught early, the overall 5-year survival rate ranges from 81 to 95%, which is encouraging. However, once the cancer has spread and becomes metastatic, the 5-year survival rate drops drastically to just about 18%. In the United States, endom cancer is now the most common cancer of the female genital tract, and its incidence continues to rise. Abnormal uterine bleeding remains as the cardinal symptom and should never be ignored, especially in postmenopausal women. In 2023 alone, the US recorded about 66,200 new cases and 13,030 deaths from endometrial cancer. Focusing now on the local landscape in the Philippines, endometrial cancer ranks as the 3rd most common malignancy of the female genital tract and 9th among all cancers in Filipino women. The median age at diagnosis is 61, which is typically within the 50 to 60 year age range. This aligns with the data showing that 90% of cases occur in women older than 50 years old. However, it is important to note that this disease is not exclusive to older women. About 20% of cases are diagnosed before menopause, and 5% occur in women under 40 years old, which shows the importance of vigilance even in younger age groups. The good news is that majority of cases, around 72%, are diagnosed at stage 1, with PGH data showing 47% of cases being caught early. This early detection offers the best opportunity for cure and highlights the importance of awareness, of prompt evaluation of symptoms like abnormal uterine bleeding. These numbers also stress the need for continued education, access to diagnostics, and timely referral, especially at the primary care level. Okay, so these are the various risk factors associated with endometrial cancer. So risk factors are primarily linked to unopposed estrogen stimulation, where elevated estrogen levels aren't balanced by sufficient levels of progesterone. So this includes significant increases in risk from unopposed estrogen stimulation. So this increases the risk by about 2 to 10 times. Unopposed menopausal estrogen replacement therapy being given to menopausal women increases the risk by about 4 to 8 times. Early menarche or late menopause increases the risk by 2 to 4 times. And obesity, of course, increases the risk by 2 to 4 times, as adipose tissue converts precursor hormones into estrogen. Additionally, nulliparity or infertility raises the risk by 2 to 3 times. Other contributing factors include certain medical conditions like diabetes, which increases the risk twice, and polycystic ovary syndrome, which increases the risk by 3 times, because this involves metabolic and hormonal imbalances. Even beneficial treatments like tamoxifen therapy for patients with breast cancer increases the risk by about 2.5 to 7.5 times due to its estrogen-like effect in the uterus. Rare but significant risk also stem from feminizing ovarian tumors, which produce estrogen, and genetic predispositions such as the Lynch syndrome, which are the hereditary cancers. Okay, so the reason why cases are increasing is multifactorial. No? Over 80% are estrogen receptor positive. So it's often driven by hormonal factors like obesity and nulliparity. So the longer lifetime exposure, the longer you are exposed to estrogen from early menarche, late menopause, and hormone supplements, this plays a key role, as does the trend of fewer pregnancies. No, because pregnancy offers protective effects against endometrial cancer. Rising diabetes rates also contribute, while declining smoking, though generally beneficial for everyone, paradoxically increase endometrial cancer cases because smoking in itself decreases the risk of endometrial cancer. Most notably, the global obesity epidemic is a major driver in the increase of endometrial cancer cases. So any premenopausal woman with irregular vaginal bleeding and any postmenopausal woman with any vaginal bleeding should be evaluated. So usually a transvaginal ultrasound is an appropriate diagnostic step to evaluate the endometrium. However, persistent bleeding should lead to a biopsy of the endometrium regardless of the ultrasound findings. So diagnosing endometrial cancer primarily relies on obtaining tissue samples for pathologic examination. The least invasive initial approach would be an endometrial biopsy performed in a clinic setting, wherein a small curette is inserted through the cervix to collect a small tissue sample. Okay, so this is an endometrial biopsy done at the clinic. Or we can use a thin, flexible tube inserted through the cervix or epipel to collect a small tissue sample from the uterine lining. This is done at the clinic. However, if the clinic biopsy is inconclusive or insufficient, or if there's a strong suspicion of cancer, a more comprehensive procedure called dilatation and curettage under anesthesia is performed in the operating room. This involves gently dilating the cervix and using a curette or suction to systematically scrape or remove a larger volume of tissue from the entire endometrial cavity. So for direct visualization and targeted sampling, a hysteroscopy-guided endometrial curettage can be performed. In this procedure, a thin scope with a camera, which is called a hysteroscope, is inserted into the uterus, allowing the clinician to visually inspect the endometrial lining for abnormalities and precisely direct the curette to suspicious areas. thus enhancing the diagnostic accuracy. All obtained tissue samples are then sent to a pathology lab for definitive diagnosis. So before proceeding with definitive treatment for endometrial cancer, a thorough preoperative workup is essential to assess the extent of the disease and to plan the most appropriate management. Aside from the transvaginal ultrasound, imaging studies may include a whole abdominal CT scan, which helps in evaluating for distant metastasis or involvement of other abdominal organs. A chest CT scan can also be done to check for any pulmonary involvement or spread to the lungs. For detailed local staging, a magnetic resonance imaging is particularly accurate at detecting the depth of myometrial invasion. So how deeply the cancer has grown into the muscular wall of the uterus, and assessing for any cervical involvement, which are both important factors in determining subsequent steps. So surgery which involves a hysterectomy and salpingo-oophorectomy with lymph node evaluation has been the mainstay, the standard of treatment. So traditionally, we remove the uterus, the ovaries, and the lymph nodes. Traditionally, patients underwent surgery through a midline incision. Today, the majority of cases with early stage disease, or at least abroad, because they don't have to pay, undergo minimally invasive surgery. There are randomized trials which have shown that laparoscopic hysterectomy has comparable outcomes to open hysterectomy, but with lower surgical morbidity. For early stage disease, minimally invasive surgery, which includes laparoscopic hysterectomy with bilateral salpingo-oophorectomy or robotic hysterectomy with BSO, is now the preferred method due to its benefits like smaller incisions, less pain, and quicker recovery. However, with a higher cost. Laparotomy, open surgery, may still be necessary in case of very large uterine sizes, when the patient cannot tolerate the steep Trendelenburg position often required for MIS, such as patients with heart problems, or when extensive adhesions from previous operations complicate the surgical field. Okay. So this is laparoscopy, which is also known as keyhole surgery. And this is a surgical technique that uses small cuts in the abdomen to perform procedures. So a camera called a laparoscope is inserted through one incision to visualize the surgical area on a monitor. Other specialized instruments are inserted in the other small incisions. So this approach results in less pain, faster recovery, with comparable outcomes to open laparotomy. So this visual comparison illustrates the difference between traditional laparotomy and laparoscopy. On the left, we see the characteristic large incision of a laparotomy, typically a vertical cut on the abdomen, closed with staples or sutures, which is a more invasive open surgical approach. The image on the right shows the minimal scarring associated with laparoscopy, where several small incisions are made to place the camera and surgical instruments. This visual evidence clearly highlights why laparoscopy leads to less pains, smaller scars, and quicker recovery times compared to open surgery. Okay, so in the LAP2 and LACE trials comparing laparoscopy to laparotomy, results show that laparoscopy has similar survival and recurrence rates compared to those who underwent open laparotomy. The quality of life is superior in the laparoscopy group, and there's less blood loss and fewer severe post-operative adverse events in the laparoscopy group. Okay, so this is robotic surgery. Robotic surgery, the surgeons would operate 4 robotic arms via the console, which allows them to use surgical instruments in the 1 centimeter incisions made in the patient. So the control console allows the surgeon to see the surgical field in an enhanced detail as a result of the 3-dimensional images transmitted from the laparoscopy cameras. The surgeon manipulates the robotic hands in real time using master control. So the instruments are designed with several degrees of motion that mimic the dexterity of the human wrist. No? So because small incisions are used instead of the more traditional larger incisions, patients can experience a faster recovery time from surgery, as well as a lowered risk of infection or other complications, and the possibility of better outcomes. However, again, at a very high cost. So in a meta-analysis of 33 studies comparing robotic surgery to laparoscopy, in robotic surgery, there are increased proportion of cases performed via MIS because it is easier to do. Surgery is easier to do because of the hand dexterity afforded by the instruments. There's fewer days in the hospital. There's lower blood loss. However, the cost is much higher. Now, this image presents a cut specimen of endometrial cancer. This is the uterus, which has been bisected to reveal its internal cavity. Within the endometrium, there's a mass which appears friable and often irregular, consistent with a cancerous tumor. The surrounding uterine wall might also show signs of invasion or the presence of necrotic tissue and areas of hemorrhage. So an important advancement in endometrial cancer management is the updated 2023 FIGO staging, which now incorporates the histologic types, the tumor patterns, and the molecular classification of tumors, and how these molecular characteristics influence the behavior of the tumor. So there's now more precise categorization. So we can now better predict disease progression, and we can better tailor treatments accordingly. Molecular profiling enables a more personalized and evidence-based treatment strategies, which will further improve outcomes for our patients. So this is the new 2023 endometrial cancer staging. I will not go into details because this is very hard to discuss. Okay, so this just shows that our patient can be upstaged if her molecular classification is P53 abnormal or P53 mutated. And her stage can be downgraded and treatment can be de-escalated if she is positive for polymutation. Okay. So the new FIGO 2023 staging system for endometrial cancer marks a significant advancement by officially incorporating molecular classification alongside the traditional histopathological factors. So this integration of molecular as well as the traditional histopathologic factors recognizes that the biologic behavior and the prognosis of endom cancer are heavily influenced by specific molecular changes or alterations. So adjuvant treatment options as well as options for tumors that have recurred are also influenced by the molecular profile of a particular tumor. So this system categorizes endometrial cancers into 4 main molecular subgroups. If your patient is polymutated, if you requested for a next generation sequencing and she's polymutated, then her category is pol mutated, which is the best prognosis. If you requested for immunostaining and there's loss of proteins of this mismatch repair proteins in the immunostaining, then your patient is categorized as MMR deficient. If in the immunostaining it shows that there's abnormal overexpression of P53, then your patient is categorized as P53 abnormal. The absence of polymutation, MMR, staining, and P53, the absence of all these factors categorizes your patient into the no specific molecular profile. So, each molecular subtype dictates different prognostic implications and the subsequent treatment pathways. So, for instance, Pol mutation carriers or polymutated cancers often have a more favorable prognosis. So these patients often have a more favorable prognosis, which sometimes allows for a de-escalation of adjuvant therapy. Sometimes, if your patient is polymutated and they are in the early stages, you don't need to give additional adjuvant treatment. However, P53 abnormal cancers are typically more aggressive and they require more intense treatment such as chemotherapy and radiation. The NSMP and the MMR deficient groups also have tailored recommendations regarding adjuvant radiation and systemic therapy, often further stratified by their histopathologic features. So this molecular classification is not merely for prognosis, but it also determines the necessity and type of adjuvant treatment. So it's a more highly personalized cancer care. Another advance in endometrial cancer management is immunotherapy. So immunotherapy represents a significant advancement in treatment, particularly for patients with advanced or metastatic disease. So the use of immunotherapy, however, requires molecular assessment, again performed at initial diagnosis to determine treatment options. That's why everyone who is diagnosed with endometrial cancer should undergo molecular profiling or molecular assessment, okay, to determine optimal treatment options. Okay, so this highlights the distinct therapeutic strategies based on a tumor's mismatch repair status. So this is an example. So for example, for patients that are MMR deficient, single-agent immunotherapy such as pembrolizumab, atezolizumab, and dostarlimab have shown efficacy. In contrast, for MMR proficient tumors, a combination therapy, typically pembrolizumab plus lenvatinib, is recommended. So this stratified approach shows the importance of molecular profiling in guiding personalized immunotherapy strategies to improve outcomes in patients, particularly those with metastatic and advanced disease. Okay, so going back to my patient, AR, a 54-year-old, gravida 1 para 1, married, was obese, diagnosed with endometrial adenocarcinoma. So eventually, she underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy and lymph node evaluation. Histopath showed an endometrial adenocarcinoma, grade 1 with a stage 1A2, meaning less than 50% invasion of the endometrium. There were no other prognostic features on the pathology report. Okay, so technically, she doesn't need additional or any adjuvant treatment because she's only stage 1A2. However, when we requested for molecular classification, she was P53 abnormal. So which upgraded the stage to stage 2CM P53 abnormal, which I have shown earlier. So she was advised to undergo chemotherapy and radiation therapy. She was earlier categorized as low risk, but now because of the molecular classification, she is now categorized as high risk. Okay, now another advancement in endometrial cancer management is fertility-sparing treatment. About 4% of endometrial cancer patients are younger than 40 years old, and younger patients may desire fertility-sparing treatment options. So patients with EC who are interested in fertility-sparing treatments should be advised that such treatments represent a deviation from the recommended standard of care, which is complete removal of the uterus and the ovaries. The patients should be counseled to consider the strength of their desire for future childbearing versus the additional cancer risks, the risk that this cancer may metastasize and become advanced later on. This discussion should be documented in the medical record. So before we offer fertility-sparing treatment, a pre-treatment evaluation is important, which include the medical and family history, molecular screening of the biopsy taken from your patient, physical examination of your patient, of course, the diagnostic procedures, ideally a dilatation and curettage or a hysteroscopy preferably, and imaging such as pelvic MRI, abdominal and chest CT scan. The use of this approach is limited to patients with low-risk disease only because the risk of recurrent or persistent disease is likely higher than if we do hysterectomy right away. So patients who are candidates should be counseled about the risks and the benefits so they can make an informed decision. In addition, patients should be counseled that adherence to oral treatment regimens may be difficult, no? As suggested by some studies on patients with gynecologic malignancies. So the strict selection criteria would include a well-differentiated tumor, a tumor confined to the endometrium by ultrasound and MRI. There should be no lymphovascular space invasion. The patient should be of reproductive age, desirous of future childbearing, with no contraindications to hormonal therapy, and there should be no poor prognostic molecular classification, and that patients with Lynch syndrome or any hereditary cancers should be excluded. Okay, so the most common approach to fertility preservation for such patients is progestin therapy, and to defer hysterectomy with BSO after completion of childbearing. Progestin therapy can be administered orally, intramuscularly, or via intrauterine. This therapy, however, requires diligent follow-up, including repeated endometrial biopsies every 3 months. And successful treatment can lead to encouraging pregnancy once 2 consecutive negative biopsies are achieved, with reported pregnancy rates of about 35% and live birth rates of 28%. However, if there's persistence of the cancer that is observed after 9 to 12 months of progestin therapy, definitive treatment, typically a hysterectomy, is warranted. Another option is hysteroscopic resection followed by progestin therapy for patients that have unifocal small lesions. And then, of course, followed by the repeated biopsies every 3 months. Lastly, for those undergoing hysterectomy, ovarian preservation at the time of hysterectomy can be considered, particularly for egg retrieval and subsequent use with a gestational carrier, providing another pathway for future parenthood. Okay, so going back to our patient, RJ, 32-year-old, newly gravid, who's a newlywed. She was diagnosed with endometrial adenocarcinoma grade 1 via a hysteroscopy guided biopsy. And she opted for fertility sparing treatment. On pelvic MRI, the tumor is just limited to the endometrium. Imaging, such as abdominal and chest CT scan, showed no evidence of metastasis. Her molecular classification is not of the poor prognostic classification. There's no contraindication to hormone therapy. So she was advised to take progestins. She was advised to lose weight. And after 2 consecutive normal-looking biopsies, she was referred to a reproductive endocrinologist. So those are 2 patients with endometrial cancer, so with different types of management according to their molecular classification and the histopathologic features of their disease. So that is the last of my slides, and these are my references. Thank you very much.
Thank you very much, Dr. Aleli De Castro Malig, for a very, very excellent lecture, I would say so. And natutuwa ako sa sa outcome ng mga patients nyo. Anyway, I think we have questions from the floor. Pero we have a second speaker pa nga pala, sorry. So we have Raymond is here.
Yes, ma'am. Thank you so much. We'll call in Dr. Aya again during the Q&A.
Yes.
For now, we'll greet po muna those who are, kasi may mga nagpapadagdag po ng shoutout. So, Also, my friends who are watching from Asian Institute of Management, maraming salamat po. The Sutra Group and Sarantis Group, thank you so much. Also, those who are joining us locally from the Wallace Air Station Medical Infirmary in San Fernando City in La Union, Valladolid District Hospital in Valladolid, Negros Occidental, May Kawayan Doctors Hospital and Medical Center in Bulacan, the Philippine Academy of Family Physicians in Manila, Orani District Hospital in Samal, Bataan. Internationally, we are also being viewed by those from the Chonin Hospital in Taipei City, Taiwan, Al-Hada Armed Forces Hospital in Saudi Arabia, and Saad Dalab University of Blida 1 in Blida, Algeria. As well as the Philippine General Hospital, Asian Hospital and Medical Center po, no, Perpetual Health Medical Center from the province of Quezon, province of, well, it's from Davao, from Rizal, Antipolo, Rizal. Thank you so much. And those from UPLB, the Philippine General Hospital, again, maraming salamat po. From Rizal Medical Center also, thank you so much. So, we'll take this opportunity po, no, to greet those who are joining us. Again, internationally naman po, from, I think from Canada naman po ito, and from the United States of America. Our next speaker is our reactor, and a reactor po, no, we already had her previously, I think for the same topic po, for gynecologic oncology. So please welcome again to your screens. She is clinical associate professor from the Division of Gynecologic Oncology at the UP Philippine General Hospital, Dr. Renny Sikam.
Hello, good morning, everyone. Good afternoon. So, congratulations, Doc Aya, on your presentation. Actually, it's very complete. So, I have actually very little to add. But I guess I just want to say that if you watch the beginning of the show, there were parang man on the street videos, and I think what people have to realize is that there is a difference between cervical and endometrial cancer. So cervical cancer is a disease caused by high-risk HPV or human papillomavirus, whereas endometrial cancer, that's the disease of the endometrium or the lining of the uterus. And typically, it is caused by unopposed estrogen, or the risk factors are associated with unopposed estrogen. So Doc Aya showed two examples of the typical patients that we encounter. So one is a patient with postmenopausal bleeding, and these are the women maybe in their 60s or late 50s, and then women who are young and they present with abnormal bleeding, like prolonged menstruation, or they skip their menses, and these patients usually have PCOS. So we have to be aware, no, as lay people and also as doctors, that these are the different presentations of patients who may have endometrial cancer. So unlike cervical cancer has screening, right? We do pap smear or HPV DNA testing. For endometrial cancer, there is no screening, and we are dependent on the symptoms of the patient. So we have to remind our women out there, and young women also, that bleeding, irregular or abnormal bleeding, or postmenopausal bleeding are symptoms that should not be ignored. The good news is, so because I said earlier that most of these cases are caused by unopposed estrogen, there are things that we can do to decrease our risk. So for example, if the patient is obese, as mentioned by Doc Aya, there is a worldwide epidemic of obesity, we can start healthy living, do exercises regularly, and have a good balanced diet. And we can basically that's it. So control our diabetes, etc. And if you do have anovulatory cycles, like if you have irregular menstruations, then you should consult your OBGYNs to ensure that you have menstruation regularly, to avoid developing hyperplasia, which could develop into endometrial cancer. Doc Aya also mentioned about the new diagnostics. So traditionally, we do endometrial biopsies and DNCs, but nowadays we can already do hysteroscopy. So we directly visualize the tumor and we can take targeted biopsy. So that's so it's more another aspect of precision medicine. Now, for the treatment, she mentioned again about minimally invasive surgery. So that is the trend. And so all over the Philippines, we're already having equipment. We already have equipment for both laparoscopy and robotic surgery. And in the Philippine General Hospital, we are teaching our fellows in this field so they may be able to serve more patients, more Filipino women. And also the established gynecologic oncologists are also seeking additional training so they may be able to offer this to the patients and with the added advantage of early recovery, less blood loss, etc. I think what's also very important in her presentation was the new staging, which incorporates not only the pathological aspects of the tumor, but also the molecular aspects. So this is a very exciting field, and it helps us prognosticate the patients more and decide with more precision what is the treatment that is appropriate. So we just don't depend on the histopath, but we also depend on the molecular classification. What's also interesting in the presentation was the topic on fertility sparing. So although hysterectomy is the standard of care, as mentioned earlier, there are cases where we can do fertility sparing, meaning we don't have to remove the uterus yet, and allow the patients to have medical management given a strict criteria, and they can still be allowed to have children. But later on, we will have to remove the uterus also because we do not want to keep the patient's risk for endometrial cancer. So I think this just ends my short comments because I think Dr. Aya already covered everything. So congratulations again, Ma'am Aya and the team. So good day.
Thank you again, Dr. Sikam. So we'll dive right into the Q&A. First question from Dr. Stella Josepa.
Actually, my question is, sometimes you see patients who, yung obese, and then they're having vaginal bleeding in their 50s, and then you tell them that it's best that they have a DNC. Some of them would refuse, and yun. So, kaya pagbabalik, when the patient comes back, mas in a bad state na. So, Dr. Aleli, what is your opinion on that? How do you solve that?
There are a lot of patients like that, ma'am, also in my practice, because they don't believe that they have endometrial cancer. They're always saying na yung word na naglalayag, or probably they're just in menopause or perimenopause. But then I tell them the usual trend of a woman in perimenopause or going into menopause, and you're not supposed to experience profuse vaginal bleeding or very prolonged vaginal bleeding if you are in menopause. So if abnormal, you have to go to your OB, you have to undergo biopsy if needed, as evidenced by your diagnostic workups.
So, for our audience, the average age of the menopause is 48 to 49 years old. So, pagka lumampas ho kayo doon, nasa 52, 53, and you're still menstruating, that's not a good sign. Go to your OBGYN already. And I have a question for Rennie naman, for Rennie. So, in your practice, I know that you do robotic surgery, diba? You do?
Yes.
Oo. So, kasi the problem with robotic surgery, it's a very good management, no? Kaya lang the cost is so expensive. It's like 1 million per patient. What do you think of that, Renee? Paano ba yan mapapababa? I mean, kawawa naman yung patients, di ba? Baka naman, there are other ways to... What is your opinion on that? How will we solve that?
Okay, so first it's you can do good patient selection first. So personally in my practice and also in PGH where we can do laparoscopy and robotics for our service patients, we use the robot for the patients who are morbidly obese. So if the BMI is about 40 and above, then we deck them to robotic surgery because it's difficult to do it laparoscopically. If they're less than that, then we can still manage this laparoscopically, which is much cheaper. So first, patient selection, get the patient who will benefit from it most. Now, regarding the cost, that's very unavoidable because the machine really costs much, but in PGH, I think it comes out to half the price, I think, usually. And if you're a service patient, then things can be done to accommodate you also. But right now, the disclaimer is the previous old machine that we have is already not in use anymore. And we are waiting for the newest model to be installed in PGH.
Thank you for your answer. Raymond, okay lang ba? I'll ask the next one. There's a question here from Mrs. Padrinao. Is there a need to wait for the immunohistochemical P16? And unfortunately, it's not no available reagent for that in our pathology in PGH. Aleli, do you want to answer that?
Yes, ma'am. Actually, I saw the questions on the Q&A box, the 3 questions, no, ma'am, and all are related to cervical cancer. No? So first one, does a monogamous sexual relationship prevent cervical cancer? Pero it does not prevent endometrial cancer, unfortunately. At what age should the female receive HPV vaccination? Around 9 years old. 9 to 10 years old. And then as to the question of Doctora Cecilia, I think, no, about P16. Actually, you don't need to routinely request for P16 if your main purpose is to determine the molecular classification of endometrial carcinoma. We would usually request for immunostaining for P53 and MMR, or if NGS or next generation sequencing for polymutation is available, then that is for poly. But you don't routinely request for P16. The utilization of P16 for endometrial carcinoma is mainly to differentiate if this adenocarcinoma came from the cervix or it came from the endometrium. Because if it came from the cervix, the P16 would be expressed, as opposed to that if it came from the endometrium. I think that is the main utilization of P16 for adenocarcinoma, but it's not really used for molecular classification, ma'am, nor does it affect the prognosis of patients with endometrial carcinoma, unlike that of cervical carcinoma.
Thank you for your answer, Raymond. Raymond, do you have a question?
Maybe one last question lang po, and this is for both Dr. Sikam and Dr. De Castro Malig. Kasi po, they're trying to ask po, no, what would be, if there's one thing that the audience po, no, not just our frontline healthcare workers, but everyone who's watching, what's maybe the single most impactful change that they can implement in their, as they try to, parang, what do they need to do in order for us to improve our early detection rates and overall survival? Parang it's like maybe you mentioned this already, Dr. Aya, about abnormal uterine bleeding in postmenopausal patients, but anything else that you'd like to add po? Thank you.
Siguro you should go to your doctor kaagad if you sense something wrong, no? So parang don't just chalk it up to may menses or like that. No, so kailangan you have to be evaluated as soon as time possible. Of course, it is also very prudent to emphasize the fact that our women are gaining weight, no? Filipino women, we have to accept that. So that's why our statistics are already copying the statistics of the US because of the worldwide obesity epidemic. So it's very important to lose weight as a form of prevention. Also for women with PCOS, it's very important for them to be evaluated and monitored. So these are women that are very high risk of developing endometrial carcinoma later on. In fact, I have a patient who is less than 30 years old. I don't know, Renny, if you have the same experience. And she was already diagnosed with endometrial carcinoma. She was around 24 years old. She had PCOS, no, but she was 24 when she was diagnosed with endometrial cancer. Stage 2 already, no, kasi because of the fact that she is obese and she has PCOS. It's very important to emphasize that also to our youth. Lose weight. Kailangan talaga ng healthy lifestyle. Sorry, it's harder to
Alam
do.
mo, yung ating parehong speakers, napakaganda ng katawan ng dalawang yan. Walang obese dyan. Kaya talagang dapat silang silang mag-promote niyan. Anyway, they're so slim, both of them, for the audience. Syempre, hindi nyo sila nakikita. Half body lang yung nakikita nyo sa amin. Pero they're both slim.
What about for Dr. Sikam naman po?
Siguro what I'd like to add is what is normal? Kasi we keep talking about abnormal uterine bleeding. Ano ba yung normal? Ano yung abnormal? So there's a criteria, no? Yung FIGO may criteria sila kung ano ang AUB at anong hindi. So yung AUB, that's for reproductive women. So women na hindi pa menopause. So usually kapag men's mo, ang criteria dyan, pag more than 8 days, prolonged na yon. Kung yung interval niya mas maikli or mas mahaba, so less than 24 days, more than 35 days. Kung wala siya sa range at yung variation niya is more than 1 week, abnormal yon. So, at saka kung napo-perceive mo, if you can perceive that the amount is more than your usual, then that's already abnormal uterine bleeding. So, dapat alam nyo yung cycles ninyo at alam nyo kung ano yung normal at yung hindi normal. So, yun yung one. And then the second is kapag menopause ka na at sabi nga ni Dr. Jose, 48 to 59, 48 to 49, pwede natin extend to 52. Kapag late, hindi ka pa nagme-menopause at 52, parang medyo kailangan ka nang magpatingin. At kung tumigil na yung menses mo for 1 year, tas nagregla ka ulit, kailangan ma-rule out yung endometrial cancer. Kaya wala pong screening for endometrial cancer. Nakadepend talaga siya dun sa perception ng babae kung normal or abnormal yung mens niya. So, dapat ma-educate ang women kung ano ba ang normal at ano ang abnormal.
Okay. Thank you. That was
Very much.
very good last message po, no? Thank you so much again to our speakers. Excellent, excellent Dr. Aya and Dr. Renny. Maraming salamat po. At this point, we'll be launching our evaluation poll. It's 5 statements, 4-point Likert scale po, no? If we can have that, there we go, on the screen. Thank you also to our 200 and plus viewers po, at least in the Zoom, but there are also additional po in Facebook and in YouTube. So I'll read through this. We'll not be closing this until the end of the webinar. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. For next week, what do we have for next week, Dr. Stella?
For next week, we have Dr. Nikki Chua, one of our infectious disease consultants, to speak on HIV.
Another it's an epidemic. Obviously that's something that we have been harping over and over, but we want you to be able to watch again. Ano na po ba yung latest, ano po ba bumababa, mas lalo bang tumataas, ano pang kailangan natin gawin para po ito ay makontrol po natin. Okay? So before we before we conclude our program, just a reminder that you can still watch this on the playback at TVUP YouTube channel and at the TVUP Signal TV channel 101. So all health updates webinars are archived for viewing at the TVUP YouTube channel. So you just go to www.youtube.com/TVUPPH. If you go to the live tab, you'll be able to see all 247 episodes. After the day, it'll be 248 episodes na po. Also, in the same channel, if you go to the Shorts tab, you'll be able to see naman po yung mga selected presentations po namin that will feature in snippets that we call Health Updates Shorts. And we hope you'll be able to watch them at your convenience at the TVUP YouTube channel po na bibigyan nuggets of wisdom from them. So this formally closes our webinar for the week. Magkita-kita po tayo ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy. See you online.